She was with us. She's still with us. She was with us in person. Luckily, we didn't lose her. She's still with us via VVC and televideo. She left because her husband had matched in Philadelphia. He's in his he's now doing his fellowship in HEMONC, and we work with her a lot. She is a great, I know I'm biased, but I think she's probably the best sleep psychologist I worked with thus far. She has a lot of, she wears a lot of different hats. She not only does CBT-I, she does nightmare restructuring therapy. She helps with CPAP adherence. She, I believe, also does pain and sleep. She'll probably can tell you a lot more of her expertise. She has a lot of them, and she has helped us a lot over the years. She's an assistant professor in medicine, and really glad that she's here to give this talk. Her reputation speaks for herself, and I'll let her
Thank you.
over.
Well, thank you so much. I appreciate the kind words, and really nice to meet all of you. I'm sorry I can't be there in person. As Dr. Gandotra said, I am actually in Philadelphia. We moved last year because my husband matched at Penn for his HEMONC fellowship, but thankfully I've been able to stay and keep working for Cleveland VA and at Case. So I would love to be able to meet you in person. Unfortunately, that's not the case, but also I want you all to know I am available to talk, whether that's through Teams when you're at the VA. If you want to send me a message, we probably will share a lot of patients this upcoming year, and I'm available as a resource to all of you. So welcome and congratulations on coming here for fellowship. For today, I'm going to be talking to you primarily about CBT-I, cognitive behavioral therapy for insomnia disorder. However, there's a few other things I want to chat with you about, although the bulk of the presentation will be on CBT-I. And can everybody see my screen okay? We're on the next slide, the agenda one. Okay, perfect. So today we're gonna cover a few things before we get into the big part of CBT-I. So I just wanna go over insomnia disorder in veterans. Can I get a show of hands? Because I actually can see you all, which is nice. How many of you have worked with veterans before in a VA, in a practicum, in a rotation? Okay, so a couple of you, great. So some of this might not be too unfamiliar, which is good. I also want to talk about my specialty of behavioral sleep medicine. So I did a specialty fellowship in BSM. I actually trained in a neurology department. So that's not too common for psychologists. So I'll talk to you a little bit about that and kind of my background. You might, depending on where you're at, are you all through UH as well in terms of where you're also doing placements? Okay, I'm not sure if they have a BSM specialist currently, but depending on where other places you've worked, you might have run into a few of us. I do want to mention what resources and treatment options we have here at our VA. As you probably have heard and will hear again, there is a shortage of people that can provide these specialized interventions like CBT-I. So it's really important to be aware of other resources and options available for patients, because even when someone is available to give the treatment like CBT-I, the patient might not want it or they might not be a good candidate. So want you to be aware of those resources. In terms of other considerations for today's talk, so this is by no means comprehensive. I consider just kind of like a brief primer, especially for those of you that don't have a background, too strong of a background in behavioral sleep medicine interventions or in psych. Again, I'm available for questions as they come up. Should you want to learn more about this, I can definitely share resources. It's an area where there's a lot of new data coming out, new research coming out all the time. There's a lot that we still don't know about this field, and there's lots of gaps. So I approach it very humbly because things are constantly changing. And probably going back a few years now, because I graduated my fellowship in 2021. Before that, I had been mostly in the area of other areas of kind of behavioral medicine, kind of like the intersection of medicine and psych, and worked in women's health, and I worked in trauma. So it's still an area where, you know, those things inform the work that I do. But again, I come to it very humbly because it is so complex. Also, no conflicts of interest to declare. And as we're going through these things, I will have some of the references up in the slide, but the rest of them are going to be in like my notes section. So for those of you that are interested, I'm happy to share my PowerPoint. So in terms of how this looks in the veteran population, the numbers are pretty high. Vets are vulnerable to sleep disorders for a variety of reasons. They might already have mental health or pain conditions coming in, and then they are put in, war zones. They're deployed where they have erratic schedules. They might encounter a lot of trauma, mental, physical, everything. And when they come back post deployment, they could have a lot of reintegration difficulties. So this is a population where you're going to see a lot of insomnia and a lot of sleep disorders. This was a review by Fulmer that was published in 2020, and they used national data, so from across the entire VA system, where there's about 5.5 million people receiving care every year. And they pulled data from the medical records, and they found that the rate of insomnia disorder has increased by a couple percent. So it's around 12% now as of 2020. What's interesting, though, is that they believe this is absolutely an underestimate, because this is dependent on coding. And as you may learn, being in CPRS and working with our EMR, if people don't code correctly, which you'll see sometimes, that doesn't allow us to collect valid information. So this is also a plug to make sure you all are coding correctly. I know CPRS can be challenging to learn. It's kind of like a dinosaur. If I'm being honest, you probably know that already. It can be tough, but make sure in terms of when you're coding to put an insomnia disorder in the diagnosis and add it to the problem list, because this lets us know accurately how many people have this condition or getting treatment for it. When we look at younger cohorts of vets, so post 9/11, we have a sample out of one VA that was nationally representative in terms of demographic factors, and they used the ISI, the Insomnia Severity Index, which is one of our best measurement tools, self-report to diagnose insomnia disorder. And they found that in that sample, almost 60% of the veterans had a diagnosis of insomnia disorder. And then when they broke it down by comorbidity, if they had comorbid PTSD, it went up to 93%. For vets with TBI, 78%. Chronic pain, 70%. And I will say in Cleveland, this pretty much tracks with the numbers that I'm seeing, and that you might see as well in younger cohorts. So you're going to have a lot of patients that are going to have this diagnosis. In terms of behavioral sleep medicine, so again, this is my specialty. We are within sleep medicine, but also I work for the psych department, so kind of across areas, but we focus on habits, behaviors, thoughts, emotions, physical factors that interfere with healthy and satisfying sleep. We have our own fellowships and specialty training. We have our own boards. So it is a subspecialty area of medicine or healthcare. We work in conjunction with other healthcare providers that are prescribing medication. So in this case, we're embedded in a pulmonology sleep medicine department. Other departments, it's neurology. And then working in coordination with other healthcare providers, whether it's CPAP, respiratory therapists, technicians, neurology, pulm, that sort of thing. And I always want to mention that people throw around different words, different language to describe different treatments or interventions. The treatments that BSM does, it's going way beyond what we call sleep hygiene. And I want to mention too that in terms of sleep hygiene, this is something that it's a word or a phrase that's thrown around a lot. It's talking about healthy modifiable factors, things you can do to kind of improve your sleep. And that could be helpful for someone that's like a normal, healthy sleeper. However, it's by no means an intervention. When we're talking about CBT-I, that is a treatment for insomnia disorder. That is a structured, manualized intervention. So want to make sure people are aware of that language and that distinction. And then typically providers in this area are going to be doctoral level. So most of the ones that I have as colleagues are psychologists, but I do have physician colleagues and dentist colleagues that work in this specialty as well. I'm sure you're all familiar with the recommendations and the practice standards, but essentially at this point, all relevant professional societies and clinical practice guidelines are going to be recommending CBT-I as a first-line treatment for chronic insomnia disorder. In terms of treatments here that are available for insomnia disorder at RVA, so certainly my clinic, behavioral sleep medicine, and this is where I'm delivering kind of the gold standard CBT-I, that's specialized, intensive, meeting with patients every week. However, I want you to be aware of these other options because you're going to come across a lot of vets for a variety of reasons aren't going to be strong candidates for that CBT-I intervention. Are any of you familiar with PCMHI, primary care mental health integration? No? Okay, so this is something that exists in the VA. It does exist in other hospital systems, although it might not be as common. And essentially what it means is that we have behavioral health specialists, like psychologists, that are embedded in primary care departments. And this is a great resource that the VA has. So basically every primary care team or PAC team across our different sites should have at least one psychologist, and some of them do sleep health interventions. It might not be the full-blown CBT-I. They might do like a kind of sleep hygiene, education, something like that. And it's not going to be as frequent or as intense. So that's a good resource for people that don't want the full-blown CBT-I. There's also multiple self-training websites people can use to learn about healthy sleep and use for kind of coping with distress around sleep. So I want to mention these so you at least are aware of them. And also they can be helpful for tracking sleep. So if you have a veteran that you want to see for follow-up and they're really tech savvy and they're able to download apps through something like Sleep Easy, Path to Better Sleep, Insomnia Coach, they can download the app. They can track their sleep, and then they can actually have it uploaded and sent to you. So what I do in treatment sometimes is use this as well. So people can send me their sleep log data and it just uploads in an Excel file. So that can make treatment really easy. So it also just has, various modules to help explain healthy sleep that kind of break apart, similar to what it would be like to go through CBT-I, except it's self-guided. So I want to make sure you're aware of this as a resource should you need it. And some veterans might prefer this versus working in therapy. So we'll move now into what is cognitive behavioral therapy. I'm going to pause and I'd love to hear from some of you that do even have a psych background, but even if you don't, what do you know about CBT broadly as an intervention?
My understanding is that you're using a lot of kind of almost motivational interviewing techniques in order to direct therapy and make changes.
Yeah, so we can kind of consider motivational interviewing as almost like a meta intervention in terms of how we approach patients and as a philosophy for how to help inspire change. Yeah, so certainly like motivation is a part of this. Anything else?
Developing coping skills.
Absolutely. Anybody else want to share, or even like your kind of reaction when you hear CBT? And if you don't quite know what it is, that's okay. So in terms of CBT, this is an overarching framework for treatment and really explains how we try to conceptualize change and how it happens. So we're approaching patients and who they are as people from a model that's biological, that's social, that's environmental, that's cultural. And we're looking at the interaction among their kind of individual factors, their personality characteristics, different behaviors they have, how they experience emotions, how this relates to their view of the world. And we're kind of looking at how they intersect because none of these things occur just in isolation, they affect each other. So someone having an experience in the world, they're going to make sense of it a certain way based on their belief system, and that's going to influence their behavior. So when we're looking at how to help and how to intervene, we're looking at all of these things in combination in real time. And we're thinking about if we make some adjustments in one area, how can we help alleviate human suffering? So that's kind of the overall framework of CBT. And very specifically, we're looking at what are thoughts and beliefs that influence this health behavior? Are there emotional reactions they have that they could learn to cope better with? and again, how all of these things interact. And this kind of overarching framework, it's present focused, it's data driven in the sense of we're constantly trying to get information on the patient and how to help. It's collaborative, and we don't really do too much of a deep dive into past history and things of that nature. And this kind of framework for helping improve health and functioning has been applied to a variety of different health conditions. And we'll talk specifically about how it applies to insomnia disorder. So when we're doing a cognitive behavioral intervention, we're going to be constantly assessing, getting information, monitoring progress. We do that through self-report measures, but trying to be objective as possible. So something like the ISI, the Insomnia Severity Index, and also sleep logs, which we'll be getting from people at each of their appointments. There's also a big focus on education. Sometimes that's, the place to start, even in cases that seem pretty complex, because there could be a lot of distress wrapped up in inaccurate beliefs about what is healthy sleep. So giving people information in that area can be very powerful. We do teach specific skills, so things they can do differently, ways they can modify their behavior to cope with different situations and manage their distress. And there's a big emphasis on putting the power on the patient to change behavior and doing that outside of the appointment time. So they might just get 1 hour with their specialist a week, but they have all the other days of the week to make changes. And we really want people to be practicing the skills that they're learning at home. In the case of CBT-I, we want people to be tracking their sleep. We want people to be going through the treatment manual and practicing the skills that they're learning in session. Any questions on this or this framework? No? Okay. I also want to mention too, in terms of how good sleep looks, sleep overall is really complex. And there's so many factors that play a role in someone getting good sleep, some of which we don't have much power to control, especially when we're talking about maybe predisposing factors that are biologically and genetically driven. But for someone to get good sleep, what we're thinking about is having a strong sleep drive. So being sufficiently sleepy by the time they want to sleep. The circadian placement or entrainment. In this modern life, there's just so many factors that can get us off schedule. A lot of us have smartphones. We keep them really close to our bed. We're constantly, using technology. I know for myself, I am looking at 3 screens right now. So that's kind of the world that we live in. And because of that, it's really hard to be living what is more of a natural lifestyle where you're actually out in nature. And you're going to see for a lot of our patients, they're struggling with these factors. The other thing is going to be low arousal, and hyperarousal and hypervigilance is going to be driving a lot of sleep disturbances for many of our patients, even those without full-blown PTSD, just people that are dealing with pain or anxiety. So all of these factors we try to address in the cognitive behavioral protocol to eventually move people towards good sleep. I want to pause for a question because I want to get a sense of what you already might know. And I was told specifically to include some questions in here for the group. So for those of you that have some familiarity with CBT-I already, I'm curious, do you know of any contraindications to treatment?
Bipolar disorder?
Yes, that could be one, especially if it's not well managed. Absolutely. Good job. Anybody else?
I think substance abuse,
Yes, active substance abuse is also correct. If we know that they're using a substance that's going to disrupt and disturb sleep, cause REM rebounds, probably want to get that addressed first, have the person do substance use treatment before doing CBT-I. And you can think broadly for this too. Anybody else? It's okay to guess.
Maybe lack of patient engagement.
Absolutely. If someone's like, no way I'm going to keep a sleep log, I don't want to see you every week, et cetera, et cetera. Treatment is voluntary. If they don't want to do it, if they don't want to engage, we really can't get started. I want to draw your attention to this decision to treat algorithm. This is from what's considered pretty much like a seminal study in knowing who's a candidate for CBT-I. And it's an older study now. You don't have to read the whole thing here. It's a lot to go through, but it's an important article and probably something you will need to know for your boards at some point. But it basically walks you through under what condition CBT-I is going to be indicated. And in terms of, meeting criteria for insomnia disorder, other untreated or poorly treated illnesses the person might have, and then evidence of other sleep disorders. So just want to leave you with that, something to go back to. In terms of our purposes, some of the major contraindications that I see, because I triage consults for the hospital system, are going to be untreated sleep apnea. And this is, of course, depending on the range and comorbidities. If there's someone without comorbidities with mild sleep apnea, I'm not too concerned, but that's really not the typical patient that would come across my clinic. So if you do have veterans with especially moderate to severe sleep apnea that are not on PAP, not in treatment, this is an area where you really want to encourage adherence, help them troubleshoot, refer them to the CPAP clinic as needed. And also I do exposure and adherence therapies for people that are struggling to use PAP. If someone has any sort of severe, untreated, or poorly treated mental illness, something like PTSD, MDD with psychotic features, or active suicidal ideation, poorly treated bipolar disorder, these are not a good time to do CBT-I if they're going through actively changes in psychiatric meds that are going to affect their sleep. If they're doing an active PTSD treatment with an exposure component, that would be something like cognitive processing therapy or prolonged exposure, things that we know by their nature will be disruptive to sleep temporarily. That's actually a contraindication to CBT-I. Active substance use disorder, as we've discussed. Any non-REM parasomnias where sleep deprivation could cause this to get worse. And that's the same thing in terms of like a seizure disorder or untreated hypersomnolence. If based on what they're going through in their life, they're having severe psychosocial stressors, that's also not indicated for CBT-I. I recently have had veterans referred to me that were victims of IPV, of stalking, people that don't have permanent housing. In those cases, it's really hard to do a treatment like this. And then again, patient engagement and ability to be adherent, because to get the full treatment protocol or an adequate dose, if you will, they have to be attending pretty much every week, maybe every other week, completing home practice, completing a daily sleep log. So these are kind of the bare minimum things I'd have to do to be able to get treatment. Any questions on this? Okay. I also want to draw your attention to this model. This is essentially the big theoretical model that drives insomnia disorder treatment, developed by Spielman back in the 1980s. It talks about kind of the predisposing, more biological factors that might set the stage for someone to get insomnia disorder. Then the precipitating factor. So what is the big stressor, whether that's a psychiatric illness, a traumatic event, other stressful life events, something like a deployment, perhaps, or having a military sexual trauma, something like that, that then starts off the acute insomnia. And then perpetuating factors are what make this condition persist across time. So when you're working with patients, veterans that, it's been not just 3-6 months, but 5 years, 10 years, 15 years, they've been struggling with insomnia disorder, you will see they've developed a lot of habits and behaviors that essentially have caused this condition to continue. So things that made sense in terms of their ability to cope when the acute stressor occurred, but as time goes on, are prolonging this condition. So people that are spending lots of time in bed, awake, things like napping during the day, and then also this process of conditioning, where essentially over time, because the person has spent so much time awake in bed, they strongly associate the bed with being awake as opposed to being asleep. And you might have heard of something called conditioned insomnia. Does this sound familiar to anyone? A couple of you? Yeah, so essentially over time, if there's been repeated pairing of the bed with wakefulness in highly aroused states, the bed becomes a cue for hyperarousal rather than sleep. So when veterans might tell me, you know, I was actually feeling sleepy when I was on the couch watching TV, and then I go into my bedroom and I feel wide awake, that's conditioned insomnia, in the sense of they've spent not just weeks and months, but years and decades being awake in bed and having a very dysfunctional relationship between their bed and sleep, where they're eating in bed, they're watching TV in bed, they're working in bed, they're hanging out in bed, and then at night they're tossing and turning, they're feeling frustrated, hundreds, if not thousands of hours awake in bed. So they've been conditioned to be awake in bed. And this is going to be a big component of CBT-I in terms of helping people unlearn this very powerful association through behavior change. So next, we're going to talk about some of the individual components of CBT-I. And it's important to note that this is a multi-component and flexible intervention that can be delivered in a variety of formats. I'm doing it right now completely virtually. I used to do it completely face-to-face. There's good evidence to suggest that results are pretty much the same, independent of mode of delivery. And it can be modified based on special needs of the patient. So there could be someone that does have epilepsy or bipolar disorder that can still get this intervention. It's just important that it's going to be modified for their safety and for their preferences. So I'm going to go through some of the kind of like the general components and talk through those individually. So as I just mentioned, stimulus control relates to this idea of conditioned arousal. And you think about the bed as the stimulus for sleep, we want to strengthen that association. And how we do that is supporting people in only using the bed for sleep. Now, the exception could be sexual activity, of course, but beyond that, we're working with this patient over time to support them in cutting out any other activities where they are awake in bed. And that would include if you wake up in the middle of the night and you can't go back to sleep, actually leaving the bedroom, doing another quiet activity until they feel truly sleepy, and then going back to bed. For someone with sleep maintenance insomnia whose sleep is fragmented, this could happen 5-6 times a night. However, with repeated practice, they're able to strengthen this association to overcome that conditioned arousal. Sleep restriction. This is a big one of the most important components of CBT-I and probably the one you hear about the most. The field has moved away from using this term. Sometimes you hear it referred to as sleep consolidation. But essentially what we're doing is we are intentionally sleep depriving people to increase their sleep drive as much as possible so that when they finally do get into bed, they're going straight to sleep. And then their sleep is more consolidated. So this is an incredibly robust element of the protocol. And it's something that I do as much as I can and as intensely as I can, as long as the patient can tolerate it. It has to be done, of course, safely while assessing other factors like daytime sleepiness. We don't want people falling asleep behind the wheel, things of that nature. You also want to make sure that depending on what they're doing during the day, you know, if they're a truck driver, operating machinery, a pilot, things of that nature, you're being really careful in assessing their daytime activities. But this is something where if people are able to be adherent to their sleep prescription or that time in bed window, they can have very quick and very robust effects. And it can very quickly help with their sleep consolidation, meaning they are so sleepy by the time they go to bed because of that restricted time in bed window. They're falling asleep pretty quickly and they're sleeping through the night until their rise time. And I want to emphasize here, I always have at least a week, if not 2 weeks minimum of the veterans or patients' sleep log data before making the sleep prescription and encouraging them to have that time in bed window. Sleep hygiene. So that's a term that came up before, just kind of talking about general education about healthy sleep and making sure people aren't doing things that are, you know, really like the low hanging fruit in terms of what's going to get in the way of healthy sleep. So an example might be, are you drinking coffee and other caffeinated beverages within a couple of hours of your bedtime? Are you doing really strenuous workouts and then trying to go to bed right afterwards? Things like that. So we're doing a lot of education in this area. We also want to make sure we are addressing hyperarousal, people feeling amped up. Some of this might be, that predisposition where biologically maybe they're just more hardwired this way, but there are things that are within our control to help modulate it. So we'll be teaching relaxation skills, mindfulness techniques, deep breathing, all these different types of exercises, do them in session with patients, as well as encourage them to practice every day, including in the evening time as part of a bedtime routine. And this can go a long way towards addressing that hyperarousal. There's also a cognitive component, which is extremely important. And this relates to a couple different things. It could be an intentional focus, an intentional bias that the patient has, where they are just so focused on their sleep, where they have a lot of anxiety surrounding it, and it becomes almost like a perseveration and obsession. They could have thoughts and beliefs about sleep that are not accurate, but they hold on to really, really strongly. Some of the most common ones I have patients hold is a belief that they can only sleep with sleep medications. So we get into kind of concerns about dependency and feeling afraid to not take a sleep medication, taking too much because of a belief that they won't fall asleep at all without it. Some catastrophic thinking sometimes, like their day is going to be absolutely terrible. They won't be able to function unless they get a solid 8 hours of sleep, and really sticking to that number. So this is an area where, being a skilled cognitive therapist really helps in terms of understanding perhaps where these beliefs and ideas come from, and finding ways to gently challenge them and give some kind of conflicting information that the patient is open to, can kind of open their mind a little bit and shift their focus. So that's the cognitive piece. And again, education is really important throughout all of this. So if there's a way to give correct information on things that they can do to improve their sleep and educate on some of these myths and misconceptions, including letting them know just what normal sleep is, because a lot of people expect they should go to sleep, their head hits the pillow, they're out, and they sleep completely through the night for 8 hours. And that's not most people. Lots of people can get normal, healthy, refreshing sleep without having that profile. So looking at those things with the patient, talking through them are all important. In terms of other targets for treatment, so in terms of behaviors, it's kind of broken down here, but we do want to make sure we're doing things to increase the sleep drive. So making sure people are sufficiently sleepy as they are getting close to bed, and also talking to them about avoiding daytime naps, because that will decrease the need for sleep as well once they get into the evening. We're also talking about ways to optimize congruency between their circadian clock, their natural biological rhythms, and then placement of sleep opportunity or time in bed. And for this, I'm trying to be as comprehensive as possible, because there's so many things in our daily lives and in our environments that can be disruptive to this, whether it's things like sleeping on the weekends, exposure to bright lights and technology. I also talk to people about their daytime light exposure, their diet, their exercise, and as much as possible, I'm trying to get people on a regular routine and a regular schedule where their body is able to predict when certain things will happen, and that can help with the entrainment. So setting a rise time, trying to get early sunlight exposure, those sorts of things, eating meals at the same time, all of this, again, in collaboration with the patient, really goes a long way to maximizing those kind of circadian factors and working with their biology versus fighting it. And when we're coming up with that time in bed window and giving the sleep prescription, this is also really important. We want to know if people have more of those tendencies towards like being, the morning larks or the night owls, and working with them to come up with a schedule that they can stick to that works with the needs and demands of their life. Working on strengthening the bed as a cue for sleep. Again, this is so, so important. A lot of people have a lot of poor stimulus control, and it leads to that condition, to insomnia. So really looking at everything that's going on in the bed, in the bedroom, to make sure that as much as possible, only sleep and sexual activity is occurring there, and that they're not sleeping during the day. In cases where people do need to take naps, it's going to be because of illness, or because of safety, or because it's a scheduled nap, and you work with the patient to plan those things. So as much as possible, again, they are on a regular schedule. reducing physiological arousal, and helping people even understand what these things are. So going back to this cognitive behavioral model where we're looking at behaviors and emotions and thoughts, we want to help people understand when they are experiencing an emotion and what that is and how it manifests. So for a lot of people, they might be able to tell you that they are having a lot of discomfort in their body, but they might not know that that is called anxiety. And they might not know that anxiety has the emotional component that you can kind of feel and that you can label for yourself. It also has the cognitive component when we talk about things like racing thoughts and ruminations. These are all part of that physiological arousal. So helping people manage these things is incredibly important. In terms of the cognitions, so helping people counterintuitively put less effort into trying to sleep. Kind of the little joke I make, not being a cat person myself, but sleep is kind of like a cat in the sense if you want to pet it and pay attention to it, it runs away from you. So you kind of have to ignore it and then it comes to say hi. It's the same thing. You know, the more stress and pressure and anxiety people are putting on trying to sleep, you know, it's not really a physiological function that we can control. Certainly we can set the stage for it to happen and try to get out of our own way. But the more effort we put into this counterintuitively, the more pressurized it can become. And we know that for people with insomnia disorder, part of the disorder is based off of this hyper focus on sleep and all the anxiety they're having around sleep. So again, we're doing that cognitive work to help, you know, shift the focus to other things and put less pressure on it. In terms of that cognitive arousal, this is something where people are really struggling because they're awake in bed, tossing and turning with all of these anxious thoughts. So, as part of the treatment and managing some of this bed and sleep related anxiety, we're doing other cognitive strategies, whether that's talking through some of these dysfunctional beliefs or doing things like journaling in a worry time, where we're having people whatever kind of the things that pop up in the middle of the night that are they're worrying about, whether it's, you know, a stressful event in their life or their to-do list, taking time every single day to address it when they're awake and not right before bed. So that's another component of this therapy. Again, talking about dysfunctional beliefs about sleep and in a way kind of playing detective and maybe, you know, poking holes in some of them if the patient's open to this. And that does require cognitive flexibility on their end. And then talking through obstacles to adherence. I always say, you know, behavior change is super, super hard. If behavior change is easy, like I wouldn't have a job and probably many of us wouldn't have jobs because people would decide what they want to do and then do it. And that's not our nature as humans, and it's not the reality that we live in. There are constantly going to be obstacles that interfere with people being able to follow through on these things. Some you can't anticipate and plan for. Other times, you know, barriers pop up and you have to troubleshoot and address them as they come. So as much as possible, trying to help people be creative and flexible to manage these obstacles so that they can have good adherence, because the treatment does work if they're able to do it. I will pause here. Any questions so far on any of these components or treatment targets?
Hey, Kristen, can you
Yeah.
hear?
Yeah.
I have a question in
Yeah.
reference to the sleep restriction
Mm-hmm.
and the time duration. Most of the literature that I have come across says that you cannot or that you should not sleep restrict anyone more than 5 hours. And I just want to kind of figure out, I kind of threw in the towel. I couldn't figure out why they picked that 5 hour period.
Yeah.
You know, I'm just kind of kicking things around. Like if you take someone who habitually sleeps maybe 5 hours, would that be okay to start out with someone like that? Or would you have to start out with a less time in bed?
Yeah. So, with my knowledge of the literature and how I was trained, I also don't go below 5 hours. Um, and I think the reason for that has to do with like safety in general. So giving people adequate time in bed and time to sleep. I think it's also sometimes because, and this is based off more like clinical practice, sometimes it's really hard to tell how long a patient is truly sleeping. And we get into some kind of challenging areas with like self-report in the absence of objective data, maybe like with actigraphy. And as I know, there are a lot of patients that really think they're sleeping not that much, just a few hours, but paradoxical insomnia is very much a thing. So I think because of that and trying to, put safety first, that might be where some of these guidelines come from. I don't know in terms of specifics, like why that has always like been the rule, or that's kind of like the absolute minimum. But typically, if someone's really only reporting 5 hours total sleep time, that's where we start. And if we can't sleep restrict further, then we're doing all the other components of treatment to see if we can at least improve the quality of their sleep. Does that answer your question?
Yes, no, thank you very much. That actually gives me a lot of insight. I appreciate it, and I think you're probably right. Safety is, because I can't imagine, the number of lawsuits and the number of, sleep deprivation symptoms somebody might get. I guess if we sleep restricted somebody less than 5 hours, like, so it makes sense. The other question I had is, what are your thoughts on? I have tried it with maybe 50 patients and have been successful maybe 2 times with paradoxical intention. Like, there's that mentality of performance anxiety, and people, I try to tell patients, sleep isn't something we do, it's something that happens to us. And, when they're lying in bed and just trying to have the mentality that, since they can't fall asleep, well, go ahead and try to stay awake if you can to remove that. What are your thoughts on that?
Yeah, yeah. So I will say in my professional life, I have not ordered someone or told someone to try to stay up or not sleep at all. But I do know that some people use these paradoxical interventions with some success, and sometimes they do work. I would say, at least for me personally, that hasn't been my style. And I think it really, it can be done, and it's like a really like high level of skill to get it to work, but it's also really hard because there's so many other factors that are probably at play in someone not being able to sleep. And not to say that you can't or shouldn't do it, it's just not something that I have really done at all. So I guess I don't have a good answer for you. I think some of that might be, if there's someone that is truly treatment resistant, maybe it would be like a last resort intervention that you could try, but I personally haven't done it.
I see. Just one other question. I just wanted to get your thoughts on,
Yeah.
I mean, they were sunsetting the subtypes of insomnia, and the American Academy of Sleep Medicine is removing them, the psychophysiological insomnia, the paradoxical insomnia, childhood insomnia. And I just wanted to get your thoughts on that. I mean, because it kind of reminds me like when
Yeah.
they used to have, like paranoid schizophrenia, residual schizophrenia, catatonic schizophrenia. They
Yeah.
removed them, because they said that there was no consistency in the diagnosis,
Yeah.
and changed the treatment plan. So it was a little bit controversial, and they removed the subtypes, and they've done the same thing now with the insomnia. What are your thoughts on that? Do you think that was a good idea, or do you think, does it affect the treatment plan in the long run?
I would say it's probably not affecting the treatment plan. And I have a lot of criticism in general of our classification systems that we use, especially in psych and the DSM. And I'd say like the lack of empiricism and how they were developed, and the lack of consistency across the multiple different diagnostic classification systems that we use. So, for us, with like psych and sleep, and we have the DSM, we have the ICSD, we have the ICD, and sometimes they match and parallel each other, sometimes they don't. I think that's like a kind of a whole conversation in terms of like how things developed and their nosology and all of that. But I would say because some of these diagnoses were more clinically derived versus empirically derived, in general, the more we're moving towards empiricism and having them really closely match data that we've objectively gathered, I would be in support of that. And to make it as simple as possible as well, because a lot of times in clinical practice, if we don't have access to these different kind of ways to assess, whether that's, actigraphy or PSG or whatever we would need to use, it makes it really hard to even know into what category people would be placed. So I guess not knowing the specific language that's in some of these things that you're referencing, it's hard to comment much more specifically, but I think that would be my general response. Things we can do to be empirically based in terms of our diagnostic categories and be consistent is absolutely something I would be in support of.
Yeah, no, I think that's a blurry area, and unfortunately with the different texts with the DSM and ICD and I think, I was hoping that there will be some more consistency that all the sources will have the same definition.
Yeah.
And hopefully that will change. The other question I wanted to ask you is airplane pilots. You were talking about different contraindications for CBT-I, like maybe like bipolar type 1 and other things, but like, are there professions like airplane pilots where you just might want to say, hey, kind of unfortunately, unless because you're in this profession, you can't do it, or do you do a modified version of CBT-I for those people?
Yeah. And I will say, people I've worked with that are in those professions, a lot of times too, they also have sleep apnea. So what's interesting is that when they're on PAP, I can look at their objective, data, because we have a way to monitor it remotely and then see how that also tracks with what they're reporting. But I would say in general, this is something where you have to be very careful, document very carefully, make sure the patient clearly understands the recommendations, be frequently assessing for excessive daytime sleepiness. And yes, probably I would be doing a more of a sleep compression as well. In any case where I'm really worried about daytime functioning, or someone has like a seizure disorder, bipolar disorder, we're not doing any drastic changes to sleep. We'd be doing more of that sleep compression where I'm working with them longer and we're making adjustments to the time in bed window that are pretty incremental. So we might do 15-minute increments over a period of a couple of months. So it's a big modification to the treatment. And again, for safety reasons, just, it's super important.
I have a question real quick.
Yeah.
For this digital, like the CBT-I apps that are used, is there a way, because a lot of these that are coming out now are actually AI language model driven, are they able to screen out, or do they screen out people, say with epilepsy or with hypersomnia? Do they actually address that?
To my knowledge, I don't know. I think the ones in VA, I mean, these are things that anybody can download and anybody can start using. So it's not like you have a doctor telling you, hey, this is okay for you to use and go do it. So in an ideal world, they're seeing a specialist like one of us, and they're knowing that that's safe for them to do these things. I guess we can't stop people from, just like we can't stop them from doing anything. Like if someone reads about this and wants to sleep restrict themselves, they might, and they probably could find an app that would support that. I'm not familiar, I have not personally used some of the other apps, although I'm familiar with the VA one, so I can't speak to that. But I think that is a really good question and something that the field could be paying a lot more attention to. But again, I think it falls into so many of these categories of human behavior where people will kind of do what they want, and we hope that they talk to us about what they're doing, whether it's they're taking 10 milligrams of melatonin on their own. I mean, there's so many different things where people are they're proceeding independently without much oversight.
Okay. Thank you.
Yeah, that's a tough one. And I did want to ask a question of the fellows, just to see what you know, because we talked about different components of CBT-I. So based on research, or if you want to take a guess, if you don't know, you're not familiar with this article, what are the minimal characteristics of effective CBT-I? So again, there's multiple components. What are the ones that we know from these single component therapies, dismantling studies that are really the most robust?
A patient would report at least some improvement, or even if they deny it, they keep showing up and working at it.
So I meant not in terms of outcome, but in terms of the person delivering the intervention. So those multiple components that I discussed. So things like psychoeducation, cognitive strategies, stimulus control, sleep restriction, sleep hygiene. If you had to pick the ones that you thought were the minimal effective amounts that would be truly CBT-I, what would they be?
I think relaxation, mindfulness is one of the easiest things to teach and the quickest. I don't know.
It's okay, you can guess. I'm going to give you the answer.
Like if I suffered from chronic insomnia, I wouldn't call it even minimally effective if I didn't feel less fatigue, or I didn't sleep a little bit longer and had less fragmentation. Those would be like, for me, like as a non-medical person.
Mhm. So I'm going to tell you, maybe part of this is confusion over the question. So in terms of the components that you would need to deliver to be minimally effective in terms of what we know to be CBT-I that works. So sleep restriction therapy, that's the big one. Like there's studies just using sleep restriction that can treat insomnia disorder. The other one's going to be stimulus control, and then some element of cognitive therapy, which is flexible. So if there's those three components, so the sleep restriction, stimulus control, and element of cognitive therapy, that package, it's considered the minimum amount that you have to give to be doing CBT-I that's effective. Does that make sense?
Yeah, I totally misunderstood the question.
Oh, I'm sorry, I couldn't hear you.
Yeah, I said I totally misread the question.
Oh, that's okay. That's okay. It's not a test, just to get you thinking. And then again, so that you know what it is in terms of when you're referring patients for it, because unfortunately there's a lot of misconceptions and conflation of language, even amongst people that do this work. So trying to be very concise there, super important. And then Dr. Condotra, is it okay to keep going? There's a few more things I wanted to mention. I know we started a few minutes after.
You have as much time as you need. Thank you.
Okay. Okay, thank you. So in terms of how CBT-I looks in my behavioral sleep medicine clinic, so this is going to be to get kind of a full dose of the treatment, usually 6 to 8 sessions. I've done it in 4, depending on the patient needs. Sometimes people pick it up really quickly. Sometimes people don't need much of the cognitive component. But depending on comorbidity, complexity, I have a lot of COMISA patients, people with PTSD and insomnia disorder. It might be closer to 8 sessions. And then after that, because we know the rates of resurgence of insomnia disorder are quite high. I'm typically doing booster sessions with people. I offer them like every 3-6 months. Sometimes people are doing great, only need to see me every year. So that's in terms of the frequency, how this looks. We're meeting typically every week. I'd say roughly 45 minutes is kind of average for an appointment. Sometimes it's shorter or longer. In terms of when I socialize people and educate them, orient them into the treatment, changing habits at home and making these adjustments to their schedule and their behaviors, that's required. I always emphasize that this program, it's manualized. There's a treatment manual that I give to patients, but it's flexible. We work on and focus on the elements that are most applicable to them. And again, what I'm going to be doing are those minimal characteristics of effective CBT-I. So pretty much everybody is going to have a time in bed window. They're going to be getting some sleep restriction or sleep consolidation, doing stimulus control, and then elements of cognitive therapy. They are tracking their sleep every week. That's a requirement of doing CBT-I. I need that data in order to be able to give them the feedback and to know how treatment is progressing. And I explain that to them. And, it's something where it has to be something the patient's willing to do and has the time to do, and it's a priority for them. It's not necessarily hard in the sense of when you get into the habit, just like anything else, you start doing it for a couple days in a row, you can do it kind of quickly, but it's something that is a requirement in order to be able to make the recommendations, go through the treatment. And then all of my recommendations will then be data-driven and personalized because I have that sleep log data. This is an example of the sleep diary. So you can see here, there's a lot of detail. Depending on how big the screen is, you might not be able to see it, but just all the different elements that they're going to be tracking. And the consensus sleep diary is something that the field of sleep medicine developed maybe like 15 years ago now. So every sleep diary that you see should have basically the same elements, and we're looking at the same important metrics. So for every week, I'm making calculations. I make them myself. I share them with the patient. I give them feedback, how long it's taking you to fall asleep, how many times you're waking up. I ask people to track things like substance use, the reasons for their wake ups, if we're concerned about environmental factors or nightmares, things like that. The wake after sleep onset, when they wake up in the morning versus when they're actually leaving their bed. Because for people with poor stimulus control, that could be hours apart. Example, someone might actually wake up at 6 or 7 a.m., but they lie in bed for an hour, hour and a half before they start their day. So things like that. We're also tracking sleep quality and getting a sense of what the quality scores mean to the patient. And then ultimately, this allows me to get a sense of what's their sleep efficiency. So how long are they actually sleeping divided by the time that they're spending in bed. And what I love to get is when people are above 90%. But sometimes people are at 85 and they're already feeling really good. So any questions on this? This is just one example. No? Okay.
So sorry, what did you say? What were the numbers you said that you try to strive for the sleep?
Oh, I try to strive for above 90% in terms of sleep efficiency, but also, paying attention to how the person is feeling. And again, depending on their unique situation, if they might need more time in bed based off of personal factors, intimacy factors, things like that, they might have a lower sleep efficiency, but that could still be a really great goal in an area where they are actually feeling good at like 85%. A lot of this is a negotiation. Like there's some folks who, and taking a step back, this sort of intervention, just like sleep medicine in general, we're not just treating a patient. Typically, we're treating a family system because people don't live in isolation. They have children, they have partners, other people in the home. So the recommendations that we're making for them, I always encourage people, talk to your bed partner, talk to your family members, because your husband or your wife might love to hang out with you and watch TV in bed. And when your sleep doctor tells them to make these changes, they might be pissed. And that's something we have to talk about. And sometimes I have patients bring their spouses to session, and it's a whole conversation where it's a negotiation. And again, you're using, or I'm using, my training as a good cognitive behavioral therapist and someone that's also a human being with my own family to help them figure this stuff out, because it can be really hard. And we want to, have that mentality in mind of, we're not making these prescriptions, these recommendations in isolation. And in terms of other treatment considerations, so I guess along those lines, I went ahead a little bit too much here. Adherence is really hard, and it's hard to measure treatment dropout and treatment success in this arena in particular, because there's so many different ways it's been measured. And as I've been mentioning, there's so many different components of CBT-I that haven't necessarily been included in all the studies that were randomized controlled trials that have been included in reviews, looking at how effective is this and how many people successfully complete it. So just adherence in general, though, we know it can be really hard. And that's why having a really good therapeutic relationship with patients is essential. Being honest and upfront when people are being informed about what treatment entails. So starting with the referring provider, letting people know, hey, are you willing to do a treatment to improve your sleep where you're meeting with that specialist, that doctor every week for 2 months? Are you willing to keep a sleep log? things like that. It's really, really important. And so getting a sense of, if this is a good time in that person's life, because there are going to be challenges that arise. The other thing I mentioned briefly is inconsistent reports and kind of paradoxical insomnia. This is, I'd say, in the clinical practice I have with veterans, it's been relatively common because of how many people have hyperarousal, anxiety, PTSD, don't really feel safe sleeping for a variety of reasons, and sometimes are just really convinced that they're not sleeping at all. So in cases like that, a lot of validation and support and education can go a long way, but also sometimes ordering actigraphy and then being able to contrast that with self-reports. Certainly that's not a perfect measurement method, but in terms of getting buy-in, sometimes it can be helpful. Evaluating for other things that are going on in that person's life, in their environment, and the life stage they're in. I speak, as a parent with a baby, it can be really hard to make changes to your sleep when you have other obligations and social responsibilities, if you're in the middle of other, big life events. So again, when we're talking to patients about treatment options, all things to keep in mind, because sometimes, with early parenthood, or maybe you just got a puppy, you're in the process of moving, it could be whatever. It might be hard to do an intervention like this. So we want to make sure people know what their options are, and also that we're doing what we can to make them feel supported and not guilty. Even if they know what the most effective treatment might be based on the practice guidelines and clinical trials, et cetera, they might not be able to do that treatment at that time. And the other thing that comes up a lot, which I won't get into in too much detail, is just the challenges with sleep medications, and for some patients a really strong belief that they need them, or alternatively having ambivalence about getting off of sleep medications. I have a lot of folks that are on multiple sleep aids. They're getting referred to me because their prescribers are concerned, especially long-term as people age, about all the side effects and the risk profiles, and they really want to get them off the sleep aids, which I can do, and I do work on with patients in collaboration with their prescribers, but that can be a challenging area when the patient themselves might not be that motivated to get off of the sleep aid. So I will end there. I want to say thank you for all the people that helped educate and train me, including at VA, colleagues and trainers. There's a lot of people that have helped me learn over the years that I continue to learn from. So I have their names in there, as well as earlier iterations of this presentation that I've adapted for all of you today. I had some collaborators, so their names are mentioned. And again, I want to say it's a pleasure to meet you. I wish I could be there in person to greet you all. I'm still available on Teams, through email. All my contact information is here. So if you have a complex patient you want to chat about, you have a potential new referral, but you're not quite sure if it's a good fit, please feel free to send me a message. I'd love to hear from you and support you in your training goals and providing great care for our patients. So thank you so much.
Yeah, thank you very much. It was very, very insightful. I really learned a lot, and it was kind of I was kind of waiting for this presentation. It was kind of
Thanks.
kind of the glue that's sticking things together for me. So you gave a lot of clarity. Really appreciate it.
Does anybody have
Thank
any
you.
questions or concerns or anything you want to ask Dr. Silver by chance?
Are we able to join you for some of the sessions that you have with the veterans? Like, I'm particularly interested in imagery rehearsal. I do imagery rehearsal for peds, but
Oh, okay.
it's different in adults, and like,
Yeah.
yeah.
We should talk, because I'm really curious to hear how it looks for children. I
Right.
imagine you'd have to make a lot of modifications with the writing component.
Correct, yeah.
Do you do audio recordings to help with the rehearsal and the practice part of it?
No, I don't have all the extra things to do. I generally just rescript them.
Mm-hmm.
I mean, I have to make it a completely different dream. Yeah, and honestly, most of them come back just like not having nightmares anymore.
Interesting.
Really weird,
Interesting.
yeah.
Yeah, I mean, I can talk about that a little bit, because I actually do 2 of the nightmare focused treatments. We have IRT, which was developed first and doesn't involve that kind of trauma focused component. And even the original IRT, you don't really talk about the nightmare at all. But what's hard, and why I always kind of am a stickler for language, is there's so many now cognitive behavioral therapies for nightmares that are studied differently and people talk about them in different ways. So there's CBT-N, which there are some people that can do in the PTSD world. And then there's ERRT, which I was trained in. So the exposure, relaxation, and rescripting therapy. And that's specific for people that have PTSD. And that maps on with trauma therapy in a lot of ways. So it's really interesting to see how different specialties are talking about these things. Because sometimes it's almost like we're not speaking the same language. So yeah, I'd be really curious to know the details of what you do. And if I do have a patient that would be willing to have someone join the session, I would absolutely be in support of that. So we should exchange contact information and we can kind of go from there.
For sure, thank you.
Absolutely. And what is your name? I didn't get a chance to hear everybody's introductions.
Oh, I'm Nina Quay.
Nina, nice to meet you.
Kate Young.
I'm sorry, I can't hear you.
Kate Young.
Kate Young.
Mhm.
Nice to meet you.
Hi, I'm Jasmine Kadana. Nice to meet you.
I can't hear anything all in the back. I'm sorry.
I'm Jasmine.
Jasmine, nice to meet you.
Hi, I'm Ronnie.
Emery?
Ronnie.
I was going to keep calling out names that are wrong. Someone's going to have to help me out.
Ronnie, R-O-N-Y.
Thank you.
Ronnie.
Yes.
Yes.
Okay, I was going to say Rory, so I was almost there, but still wrong. Okay. Dr. Gandotra, maybe what you could even do is maybe send out an email with everybody, and then that way everybody will have my contact information. So whether or not you're in the VA network or not, you can still reach out to me. And I saw someone with their hand up.
Just a quick question, don't hold
Yeah.
it up because, we can email each other. How many, just kind of to assess the scope of your practice, how involved you are in this aspect of insomnia and chronic pain management?
Mhm.
How often do you do CBT-I for that? When all the pharmacological options were exhausted, or as an adjunct or vice versa?
Yeah, so there are, as I mentioned before, CBT, so cognitive behavioral therapy, has been applied to so many health conditions. There are specific cognitive behavioral therapies just for chronic pain. I was trained in them. I used to do them back in Durham. That's where I did my training, and I worked in their interdisciplinary pain management clinic. So in my role here at the Cleveland VA, I don't work in the chronic pain or pain management clinics. They've had me working in the transplant clinics. I used to do the pre-surgical evaluations, certainly sleep medicine. I worked in women's health for a bit. And now I'm doing mostly sleep medicine, and I also help run a tinnitus management program with audiology. So those are my current roles. So since I'm not doing treatment right now for chronic pain patients, when I have a patient that does have chronic pain and a sleep disorder, because of the role that I'm in, and because of my job, I have to focus on the sleep disorder. That's the treatment that I am providing, and that's the focus. However, certainly my knowledge base of how to help manage chronic pain can be integrated into the treatment protocol. So I would consider it a modification, and also wanting to be collaborating with whoever their other treating providers are. So if it's something where they're getting, physical therapy and they have a chiropractor or whatever it is, they're on different medications that perhaps would be contributing to some of their sleep problems. So a really common one, people that are on different pain meds or muscle relaxers that are falling asleep during the day, and that's impacting their functioning and safety and things like that. As much as possible, collaborating with whoever the other healthcare team members are. That's the nice thing about VA is, for the most part, the care is integrated. So I could send that other provider a message and say, hey, can we chat about such and such that they're on because they're telling me they're falling asleep and I'm really worried about them driving, et cetera, et cetera. And we can see if we can make some changes that might be helpful for them if the patient's in agreement with it. In terms of how to treat chronic pain, a lot of the cognitive behavioral strategies we use are coming from this modality that's called acceptance and commitment therapy, Does this mean anything to any of you? Have you heard of this before? Is this like modality of treatment? Is it in the back? I see some nodding, maybe.
Yes, yeah.
Okay, okay. It's kind of hard to see, like like not only is the audio bad, but like it's blurry. So we would develop basically a protocol that we could do together that's still trying to, wear my hat of treating the sleep disorder. But if there's things they're telling me about how their chronic pain is affecting them, we're making modifications and trying to address that as well. Whether that is maybe taking some time to process grief in relation to adjusting and accepting the pain that they have, working on acceptance strategies like radical acceptance, and choosing behaviors and activities that are really aligned with that person's values and allow them to still live a life that has meaning for them despite the limitations. Now, I say that simply, it's incredibly hard because for a lot of people, that's just so painful to do, to have any sort of acceptance of the fact that they might be very impaired and living with a lot of pain. However, for a lot of pain conditions, they're chronic. There is treatment but no cure, and treatments have their limits. So that's why, again, some of these kind of skills we've been discussing in terms of like coping and emotion regulation, flexibility, to adjust goals and expectations, all of that are things that can be looped into the treatment that we're doing, because my goal, of course, is to improve people's sleep, but I also want people to live meaningful lives. So we're talking about what they're doing during the day and their activities and the people that they care about. All of that can be looped in to the treatment that we're doing. So yeah, I know that's a really long question. I hopefully gave you a long answer to your question. Hopefully that gave you some context and answered it mostly.
Absolutely, thank you.
Yeah, as I start talking, I was like, wow, I can talk a lot about this. I need to stop. Anything else I could answer for you all? Well, again, feel free to reach out. My contact info is up here. And then, as I said, so if you want to refer a patient, talk about a patient for a sleep condition, you have my information. And then the progressive tinnitus management program that I'm running now with audiology is also open and accepting new patients. So if you get a patient that you see in the sleep disorders clinic that has really bad tinnitus and wants treatment for that, that would be another option. So you're welcome to send me a message about that too. And then also you can let the patient know they can actually call the audiology department. It's direct schedule. We don't need to like place an order for it. And then they can get into our group program that way. So that's another treatment option to be aware of.